with us on today's webinar. Hey everyone, welcome. Thanks for being with us. Just your patience for another moment, we'll get started. Well, hi everyone. I am Michael Morella, Managing Editor at US News and World Report. Thanks so much for joining us for today's webinar on improving health equity and access through telemedicine and new technologies. Our experts will discuss what's working and what challenges remain to be overcome. Today's session is the latest installment in our Healthcare of Tomorrow virtual event series, exploring critical issues facing hospital and healthcare leaders across the nation. You can learn more about future programs and find links to previous videos, recap articles, and full bios of today's speakers at usnews.com/healthcareoftomorrow. We are recording video of today's session and we'll be archiving that on usnews.com. We're also simulcasting on the US News Facebook, LinkedIn, and YouTube pages. Now I want to welcome the panel, but before I do, one more note: if you have questions, we ask that you please type them into Q&A in Zoom on your screen. Later on in the discussion, we'll try to make some time for those questions, and our moderator will give voice to them as we can. So now I am very pleased to introduce that moderator in our panel. With us today, we have Dr. Tiersani Davis, Director of Clinical Programs and Strategy for the Center for Telehealth at the University of Mississippi Medical Center; Isaiah Nathaniel, Vice President and Chief Information Officer of Delaware Valley Community Health; David Sides, President and Chief Executive Officer at NextGen Healthcare; and Tressa Springman, Senior Vice President and Chief Information and Digital Officer for Lifebridge Health. Thank you all. Now I'll turn the mic over to my colleague and our moderator, Liz Whitehead, Managing Editor with the US News Live Events team. Liz?
Thanks very much, Michael, and welcome to our audience and outstanding panel. In the last couple of years, the pandemic has only highlighted the glaring inequities in our healthcare delivery system. If there is a ray of hope, it has been in the expansion of telehealth and new technologies that are helping bridge critical gaps to improve service to many communities. David, if I could start with you. You serve many healthcare systems throughout the country at NextGen. Can you start us off by surveying the landscape for us? If you look back at the last 5 years, how would you characterize the emerging impact of telehealth and new technologies on underserved communities? And do you see now a faster learning and implementation curve of these new tools?
Liz, I think we were all affected by the pandemic, and it was amazing to see our healthcare organizations respond immediately when everything stopped. There were people that had implemented virtual care ahead of time and were prepared. And then there were almost everyone else who had not used virtual before and implemented systems in a matter of days and weeks, when what those projects would have taken months before. So I think we learned how rapidly our organizations can change. And we all saw the power of virtual care when there were no other alternatives. And some of that has really persisted. So what was before something that visionaries thought this is a way to treat patients and meet people where they are and improve the patient experience. So, for example, during COVID, I think we all have sympathy now for, I have a physician practice appointment that's coming up. Now I have COVID. So instead of skipping that practice and having this inefficiency of unfilled care, not getting my treatment, now I have a virtual visit. And a lot of places are finding the effectiveness of virtual visits and that you can treat people more quickly in many scenarios than you could before. And you can reach a clinician who may be able to meet your needs better than you could before. Mental health being a great example. I'm from a small town, and if you're in front of the psychiatrist's office, everyone knows that you're there getting treatment. And if I need some specialized treatment, well, that's too bad. There's only one psychiatrist in town. We've all seen now you can match with people anywhere in your state, get the care that you need at the time you need it. And then if you add that to some of the things that have advanced, from a government perspective on interoperability to try to defragment care with the Cures Act and others, I think we're in a really good time in healthcare when you can treat people where they want to be treated, and you can gather all the information to combine it up into one record so that things aren't missed and I'm not falling through the cracks. And that point of access is not just for access is improved for everyone, is what I'd say. not only for the people who had difficulty with access before, Liz, with your example that we talked about, when you needed a specialist at a right time and they weren't available, even with the best insurance, you can be without access. So I think we all need to think through those and then think about that as how do we improve access, especially for the underprivileged and underserved, and take that, that feeling forward of, if I need a neurosurgeon and there's not one here right now, that I can get them virtually now and maybe get the treatment I need, is something that we should think of for all of our fellow citizens for all times.
Thank you. And Kirsten, if you can pick up on this, you direct UMMC Telehealth, which is a national telehealth center of excellence. And so you have been in the forerunner of advances in this area, particularly with underserved communities. Can you give us a sense of the range of the communities you serve, who you partner with, and the services you offer? And then later in the conversation, I'd like to delve in deeper on some of these.
Yes, so we have been doing telehealth here at the center about 20 years now. And we partner with hospitals and clinics all over the state of Mississippi, primarily within the state of Mississippi. And, it has, when I think about COVID and what COVID did for us, ironically, most of our work is done outside of the medical center. And what COVID really did is it brought attention to that. We had more activity, more requests for telehealth immediately. I say on March 13th, I went to sleep, and on March 13th, I was begging people to use telehealth. And on March 14th, everybody was beating our door down saying, how quickly can you get telehealth up and running? But similar to what David said, those that had been doing it before, they were ready, and they were just doing more of it. But those who were not ready were scrambling, trying to get telehealth ready. So I will go into more detail about how we partner, but we partner with, many different types of groups.
Tressa, can you talk about the multi-hospital system and affiliated units and subsidiaries you represent at Lifebridge Health, and how you see telehealth and new technologies reflecting your philosophy of offering maximum flexibility to patients? And ideas, by the way, I think whose effectiveness you're able to try out on your own employees as a self-payer insurer. So can you talk a little bit about that?
Sure. Thank you, Liz. Yeah, Lifebridge Health is a integrated delivery network in the Mid-Atlantic area. All of our entities are actually in Maryland. So we do have the benefit of an unusual relationship with the Medicare waiver that really, really encourages us, because we're reimbursed for value, not volume. And so it's allowed us really to try some of these interventions that perhaps others haven't had the reimbursement headwinds to try. But Lifebridge has 5 acute care hospitals. The majority of our revenue, though, is on the outpatient side: practices, pharmacies, urgent cares, ambulance services, assisted living, etc. In mentioning what motivates people and what makes them compliant, we're really taking the philosophy of choice. Everyone on this panel knows that we've got a real range of comfort with technology, with the patients that we serve in our communities. And we talk a lot about personalized therapeutics. We're looking at genomics to help with that. But what we're finding with our digital strategy is that we've got to be omni-channel. We've got to offer all of these modalities to the patients we serve where clinically appropriate, to make sure that we're able to meet them where they are. If audio only is an effective intervention and it's the technology they have access to so they don't miss that workday, and again, it's clinically appropriate, we need to make sure it's available. For someone else, perhaps they just really have a comfort and a level of acknowledgement or self-awareness that would require and necessitate the desire for that in-person visit. We've got to make sure that as a mode is available too. So it's really about preference management, not only to recognize people as individuals, But we also believe that it helps with compliance. It helps with creating a little bit of control over choice of the care setting. As you mentioned, Liz, Lifebridge Health is self-insured. So we do have the opportunity to understand what kind of behavior changes and sometimes clinical outcomes we will get if we introduce a new technology choice for an intervention to the employees that are our patients. More specifically and recently, we have had some successes with an asynchronous technology. Many people are familiar with a video visit, which is a synchronous technology. Async is texting. Here's how I'm feeling, and having a real-time clinician on the back end responding to those texts, but not necessarily at the same moment seeing you. It's more of a back and forth dialogue. So we're evaluating that right now before we introduce it to the communities that we serve to see, is it perceived as too impersonal? Are we getting enough uptake? And by the way, is it getting our employees to the right level of care? We also have had some really recent good success with behavioral health online sessions, especially for our nurses. And that's allowing us to study with our own associates if these type of investments are going to make a difference and offer that same value to the communities here that Lifebridge serves in Maryland. Before we put all those dollars on the table, we have that opportunity in a bit of a safer setting to see what our own associates are finding out.
Thank you. Isaiah, Tierney set you up a little bit. Can you, at Delaware Valley Health Center, you work, or you serve as a federally qualified health center. Can you talk a little bit about how you saw your patients right before the pandemic, and then what happened with the pandemic and what you had to do? It's quite a remarkable story.
I'm happy to do that. But first, before I do that, Liz, I just want to say it's a pleasure to be here. I want to thank US News. I want to thank NextGen for putting together this amazing panel. I'm just happy to be a part of the conversation. But who am I? I just happen to be the Vice President, Chief Information Officer for Delaware Valley Community Health, which is a 52-year-old federally qualified health center that is headquartered in Philadelphia, Pennsylvania. For those of you who don't know what an FQHC is, we are a federally funded by HRSA organization that serves the underserved. Our mission is to serve the underserved. And what that means to us is that regardless of your ability to pay, we will see you. So that means you can walk in with commercial insurance, you can walk in with no insurance at all. And it doesn't matter to us. We will still treat you as a patient of care for us. And then through a 330B grant delivered by HRSA, we're made whole on that visit. So for us, that turns into 52 years, 350 employees, 9 locations, and about 158,000 visits that we see for 50,000 patients per year in the traditional primary care space. That's internal medicine, optometry, behavioral services, pediatrics, dental, behavioral health, OBGYN, and women's health services. That's all the services that we offer through our 9 locations. And we, Delaware Valley Community Health, is just one of 1,400 federally qualified health centers and lookalikes in the country that annually serve about 29 million patients. But now let me get into the specifics of the question, Liz. The question was, how did we do it in this pandemic? So when the pandemic started, I would never forget that weekend, which was the weekend of March 20th. And we said we have to close our doors to that 50,000 patient lives. But how do we see them? Technology is the way that we did it. So I made one phone call to our EHR vendor, and then within a week and a half, we had a fully integrated telehealth application. But being in Philadelphia, being in the urban market, we, before the pandemic, had zero telehealth because as an urban institution, it wasn't deemed reimbursable by the federal government. But with the EUA and all of the mandates that were restricted, we were able to provide telehealth services. So we went from 0% to 100% in a weekend. And so I'm happy to report that throughout the pandemic, just that first year, we saw 47,000 telehealth visits. And that kept our business afloat, that kept us open as an FQHC, serving the underserved And I'm so happy and proud to report, Liz, that throughout that time, we laid off not one individual, which means a lot to us at Delaware Valley Community Health.
I just want to hit one point. At Delaware Valley Community Health, the patients you serve, you are the only source of care they have for many of them, right? So if they couldn't get care, they would have been in a fairly desperate situation. Is that correct?
That is absolutely correct. But that's our mission. Our mission is to know our patients, know where they are, and know how to get to them. And I know we're going to get into that. But similarly, with our patients, it's the same for our staff because we hire from the same communities that our patients come from. So when you look at that patient and that staff profile, when I look at that as being the CIO, my charge, what gets me fired up and what gets me coming to work every day is to say that I can put technology in front of my staff and my patients, and we can make that patient a whole person. And aren't we talking about the healthcare tomorrow? So I'm just excited to get into this conversation, to discover many of the things that some of my colleagues are doing and how can we implement that for those that need it the most. I'm so happy that we have the technology, we have the EHR, we have the integrated applications that allow us to not only see the patient for one service, we see the whole family. So when we talk about SDOH data, we talk about food insecurity, housing insecurity, education security. That's all we have in my technology system. And we're happy to share it with our hospital partners, our referring specialists. We're happy to play our role in healthcare of tomorrow.
Well, David, Isaiah has raised some important points, social determinants of health. Can you talk a little bit about analytics and its ability to impact underserved communities who are already under enormous amounts of stress, housing, food insecurity, and so on? How can data analytics help with these challenges? And can you offer an example of it in action?
Yeah, I mean, Liz, even with our clients doing 3 million virtual visits, to Tressa's point, people don't have phones. So how do you meet people where they are? We've seen some really interesting things with some of our clients, like Nashville Health, or Neighborhood Health in Nashville. They have gone to the homeless camps using mobile, and they treat people where they are. And then they try to track people to say, if they needed a COVID shot, for example, how do we get the second COVID shot? And that has just been, a really great story of just meeting people where they are and kind of moving things forward. We've done things with Circuit Clinical to get experimental drugs or new clinical trials to the underserved. So you see a lot of difficulty today if there's a new drug or even a new vaccine. How do you ensure you've got it across the entire population? So you see any outliers that there could be, and get people to access to the same life-changing or life-saving, drugs that you would get in a normal clinical trial. Bringing those to the underserved as well, so that you can get the latest cancer treatment and be involved in that trial if it's appropriate for you. So those are just two examples. I really love the one where they're treating people where they are. Instead of, you don't have a phone to call me virtually, I'll bring my iPad or my phone to you, and we'll treat you where you are.
Yeah, that's really fabulous. So, Tierney, one of the incredibly important applications of telehealth is improving chronic care management. Can I ask you to pause now and take us into a little detail about how you work with clinics, primary care practices to manage chronic conditions, and then talk about how you see measure outcomes, the improvement in outcomes?
Yes. So when Isaiah was talking about the fairly qualified health centers, I was getting almost as excited as he was because the fairly qualified health centers are some of our best partners. They actually make up our largest group of partners. We have chronic care management with them, what we call our remote patient monitoring program that we work with them on. And then, of course, our mental health program. They are our largest partners with our mental health program, but I'll start by talking about the chronic care management program. So remote patient monitoring is what we do. We monitor for hypertension, diabetes, heart failure, we have asthma and COPD. But right now, mostly they are focusing on hypertension and diabetes. So we have a team here of nurses, and this is what they do all day, is we send out a kit to the patient. The kit consists of a iPad mini, and it has whatever device, peripheral devices correlate with that patient's chronic condition. So if the patient has hypertension, they get a blood pressure cuff that is Bluetooth, that is paired with that iPad. And then if they have diabetes, they get the glucometer that goes with it. And if they have heart failure, they also get a scale that goes with that as well. And then the patients do the, here's something else. So the patients do what we call their health sessions each day, that collect their biometrics, and all of that information goes over to our care team, to our nurses, and our nurses monitor that. And I know that many organizations do that. That's not new. Monitoring that information is not new. But what we have added to that is our patients are also receiving education. So if the patient has diabetes, they are receiving the diabetes self-management education course while they are on this program as well. So if you are a patient and you are living in a remote area, it is very easy for you to go to your provider, and that provider says, well, we have a diabetes self-management education course, and you can come to this course, once a week. It's in our clinic, for an hour, and get this training. Well, we're making a lot of assumptions when we write that order or ask that patient to come to that clinic. We're assuming that they have transportation. We're assuming that they have time. We're assuming they have childcare. We're assuming a lot of things, but they very well may not be able to make it. If they don't show up, we're also making a lot of assumptions. We're saying that that patient is non-compliant. There are lots of things that we say, about patients. So with this, what we tell our providers is, if the patient completes this program, at least one thing, that they have received that education. So what providers are telling us is, they're telling us that when the patients come back to the clinics, the patient is better able to have more productive conversations with them. When they're talking to the patient about their disease state, the patient actually knows what they're talking about because of their interactions with the kit, but also their interactions with that nurse, because the nurse, they are assigned a nurse. So that nurse on the other end that is monitoring that patient's biometrics actually gets to know that patient. So they're talking to that patient. They're calling and checking in with that patient. If that patient's biometrics are outside of the parameters, that the individualized parameters that have been set for that patient, they're giving that patient a call to see, what's been going on today. I see that, your blood sugar was 300 and your blood sugar is usually under 200. And they're just talking to them to help them figure out what can they do differently the next time. We're not scolding the patients. We're not putting all of the patients on the 1,800 calorie ADA diet. We're not telling all of the patients to eat broccoli and Brussels sprouts. We're in Mississippi. These patients, don't all live near a grocery store. We have real food deserts, and they're not few and far between. The really nice grocery stores are what is actually few and far between, here in Mississippi. And so back to outcomes, we are actually measuring, outcomes on these patients. I tell all the providers, what we are doing for you is what you wish you could do. We all wish that we had a diabetes educator within our clinics. We all wish that we could, write that care plan for the patient, give them that treatment plan, and then know that the patient actually took that medication and did what we asked them to do within that 3 months, between the time that they saw us and that next visit. But the truth is, we have no idea what that patient is doing, until we see them that next time. If the patient is on remote patient monitoring with that nurse that is a part of their care team, we do know what's going on. What we also do is we communicate with their primary care providers. So let me give you the scenario. If the provider is in that FQHC and they put the patient on remote patient monitoring that is powered by UMMC Center for Telehealth. So that's what we call it. When we call that patient, we don't call that patient as UMMC Center for Telehealth. We're calling that patient as that FQHC provider. So we are an extension of that FQHC provider. So, and then when we find that something needs to happen, an intervention or whatever, we're going to notify that provider. So if we made any type of medication adjustment, insulin adjustment, or whatever, we are sending that provider what we call a continuing care document that lets them know that we made some type of change. So they are not left out of the loop. Everybody knows what's going on with the patient, and everybody sees, the productive outcomes on the patient. So when that FQHC is doing their yearly reporting, on the patient outcomes, they have all of this. They have all of these results. So everything is tied back, to the work, and the patient, the primary care provider, and our care team. We're all partners in this together.
That's great. Thank you. Tressa, David mentioned behavioral health, and I'd like to use that as a sort of stepping off point for you. Lifebridge, I believe, had an interesting program with providers in South America to offer telehealth care. You can use any examples you want, but if you want to start with that one, can you explain how that solution presented itself to you? Were there special regulatory hurdles? How did that occur to you? And how has that worked? And then finally, how does this integration of telehealth options into other specialists, who see patients in person versus also with telehealth, how does that expand how many people you can see, which is a particular value, I think, to underserved patients who don't have a lot of access to specialists?
Thank you, Liz. I think everyone is hearing about the shortage of clinicians that we have currently. And technology has not been the barrier. What you're hearing is technology was ready. We weren't just ready for the technology. And, in these areas where we have access constraints to specifically qualified specialists, the technology really can make a difference, because it really provides a multiplier effect for others that might not physically be able to access that specialist. As Tirsani said, sometimes they don't have transportation, and sometimes it's really just an absence of that type of a provider or that type of specialist in the area where you are. And it's great to hear about these rural populations, because this now is being amplified all over the US as we see more and more shortages of clinicians. So back to the ask of behavioral health, and I'm going to switch the example a little bit. I have the pleasure of overseeing our digital care center here at Lifebridge. And by way of example, in the evenings at nighttime, we have some fantastic US prepared nurses that happen to now live in Israel. They're our employees. Unfortunately, Medicare will not reimburse what they do. However, as I said, they've all gone to US institutions, have their nursing degrees, and we have the benefit of a time difference. And so besides the nurses, we have a couple of social workers, and who during the evening in our ERs, they offer that ability after a patient has been medically ruled out. They are able to do a behavioral health evaluation. They're able to make a diagnosis, put together a treatment plan, etc. So they're able to do that across many of our ERs, as opposed to a singular ER where otherwise a physical presence is required. We're looking at examples like that, Liz, in a lot of different specialty areas, not only to offer a level of service that, for example, today many nursing homes don't otherwise have access to, but really would benefit by, as well as identifying digital opportunities for these offshore nurses to take some of the non-bedside care duties off of our inpatient nurses, which are another area of constraint for many of us. So again, it's got to be clinically appropriate, and it's challenging us to redesign the way we do work. And those changes are very, very hard, but it creates such benefit where there otherwise are geographical barriers, there's socioeconomic barriers. It allows that choice.
It's fascinating. Isaiah, If we could, again, pick up on a point that was has been made several times in conversation about managing social determinants of health. I'm interested in how you handle data management and exchange in the needs of a particular patient. So you told a quite amazing story of one of your patients who lost a home right before an appointment, one of your clinics. Can you talk about that, and then talk about how your ability to manage holistically the patient and how you were able to connect services help that particular person with their needs?
Yeah, I'm happy to. It's a great success story for us at Delaware Valley Community Health, but it's only one of many. But before I get to the story, I like to lay the framework and lay the status of it by talking about standardization of tools and technologies. And that's what is part of my charge and part of my platform, is the standardization of not only the tools from an interoperability perspective, but the standardization of workflows. Having 9 locations, for us, we want to make sure that each of them function in a way that's applicable for every patient, regardless of where they go. So out of those service lines, we may only offer dental at one of our locations, or we may only offer behavioral health at one of our locations. And that's where telehealth and the standardization, or the integrated model, as my chief medical officer would say, the integrated model of care. That's how we operate as a business. So by having this standardization, and I want to credit a lot of the work that's done at the national level on the prepared template, something that came up from our National Association of Community Health Centers and is now integrated into our EHR. We use that faithfully. We use that to identify what is our social determinants of health at every visit. And so the patient in question was coming to her visits, and then one particular day, our care coordination and our front desk teams noticed that her car had not moved from the night before. So she's in front of one of our centers, our administrative building, and her car did not move, but she came in for the visit. And so the visit occurred and she went back out to her car. She had a follow-up appointment, and then 2 days before, we noticed that the car returned. And so when they came in, the patient came in, it was asked in our interview, in the patient intake, are you homeless? And the answer was yes. And so we identified that visually, but the technology allowed us to capture that. So when the patient went to the provider this time and they saw that, she quickly went into action. And this patient was a diabetic patient. So this is how we are able to see the whole patient at the point of care. So understanding that this was a high critical patient who lost their home, is not eating properly, because you can see that they had pizza and a burger from a fast food restaurant the night before. And so how do we deal with that? So we quickly jumped into action. Our administrative team got involved, our clinical coordination teams got involved. The whole care went to this person, and we were able to identify where she was living, what potentially happened, and then using another tool outside of our prepared template, we were able to place that person in the home. So had us not be physically aware, using the technology in an integrated fashion and being who we are as an FQHC, regardless of the ability to pay, I'm just going to keep saying that, regardless of the ability to pay, we will see you. So walking in, understanding that you had no home the night before and you just were driving around and would try to get a parking spot 2 days before your visit so you wouldn't miss that appointment. That's what Delaware Valley Community Health, that's what FQHCs are about. That's what's healthcare today.
Yes, David, can you pick up on some of Isaiah's points and talk a little bit more about how EHR and these various analytic tools better help meet the multifaceted needs of underserved populations, and maybe are opening up opportunities for innovation in how multiple needs can be identified and then addressed. And I think that there was a dental care initiative in Columbia, Missouri that you mentioned that did this. It showed the kind of creativity that would allow healthcare providers to really go into their patients' lives and not deal with the issue of the day, but a multitude of issues. Can you talk about that a bit?
Yeah, so Isaiah talked about whole person care. The next gen system supports dental, mental health, medical, even chiropractic, kind of all the health realm someone might come in on. So we have the prepared template in the system. We track things like the ability to get to transportation, to get their visit. And if you see that, people arrange that for them. One of the examples is the Compass Health Network in Columbia, Missouri. I was there a month ago. They used the EMR, so they had a lot of no-shows, as you would expect if you're serving a indigent population. And you can have the clinic as close as possible, but even transportation being offered, people don't want to take it for a variety of reasons. And so they had a lot of no-shows. They moved their whole business to same-day see and treat, which is a huge operational change, but it eliminates a lot of complexity around no-shows and reminders. It's, hey, it makes it, I think, a really welcoming place and culture of, if you have a need, come here and we'll help you. We'll treat you. To Isaiah's point, regardless of need, they're an FQHC too. And they get a lot of people coming in because of dental. So I might be diabetic, but when I go into Tiersany's point, they scold me, so I'm not going to come in. But now I've got a toothache, and nobody's going to suffer through a toothache for too long before you eventually come in, and that's an entry point for them for a lot of people. So people come in to have dental care, and there's a reason that they got to that point. They say, look, we'd like you to meet with one of our life coaches. We know you might be depressed from this pandemic. That's natural, normal. We've got life coaches that work with you on it. They're not therapists, because the therapist, nobody wants to see a therapist, but a life coach. We're just trying to help you through. Now, they are licensed therapists, right? We know, but it's one of the ways they start to treat the mental health to then improve their physical health. And they came in because of a toothache. So I love those kinds of stories of just thinking through, how do you meet people where they are? And we've got other clients like Contexture, which is in Colorado. It's a health information exchange. It does interoperability between, anything, any healthcare provider. And they've run things to check on if there's a measles outbreak or COVID outbreak. How do we track people and get them back in, so that from a public health perspective, from a statewide perspective, we can be sure that we're not, declining the health of the population because all these fragmented things aren't joining up. So it's another way to use the social determinants of health. I see there's pockets of a population here that is kind of doesn't like vaccines. All right, we're going to go work in that group and get them vaccinated so that they don't have, deaths in their children from measles, which is, 100% preventable. It still happens, unfortunately. So just thinking through some of those things, taking that data and analytics in a new way and applying it to some of these problems that have been with us for a long time.
Tirsany, it seems just about everybody in healthcare acknowledges the value and importance of telehealth now, and yet there are still reimbursement issues. Can you talk about what you're trying to navigate in Mississippi, whether you feel that you're having success in knocking down some of the barriers, or what are the arguments still against it, against the reimbursement?
Well, I would say that we are making progress in some areas, but there's still a lot to be desired. We've had reimbursement parity in Mississippi for telehealth since 2013, when a lot of states still did not have reimbursement at all. Okay, so I'll start there, but I will say that even then there were still lots of restrictions. There were still lots of conditions. So we did not reach a lot of people still. So even for remote patient monitoring, we got a reimbursement for remote patient monitoring in 2014 in the middle of our initial diabetes study for remote patient monitoring. But even then, there were restrictions. Patients still had to have 2 hospitalizations or ER visits for whatever that condition was, for that chronic condition. While we were excited that we got reimbursement for something with remote patient monitoring, we still felt like that was more reactive than proactive. Like, why wait on the patient to have to go to the hospital or have to be in the ER before we, reimburse for remote patient monitoring. So we know that we still have to prove it out, still do the work to go back and be able to say that this is effective and we do need to reimburse for it. But we're used to this. We had started our teleemergency program back in 2003 and did not get any reimbursement for that for 10 years, before we got the 2013 legislation for reimbursement, for telehealth. So you still, you just have to do the work and prove it out and show it. We're doing work with FQHC partners. A lot of our work with those partners, FQHCs can get reimbursed for a lot of telehealth, but there's still some work that has to be done there. And we want to show that not only, organizations like ours need to be reimbursed for the work, but FQHCs need to be able to do some of this and get direct reimbursement for it as well. So, we still have to just work through those issues. RPM for maternity health, in the absence of chronic disease, in the absence of hypertension, in the absence of diabetes, we need to get reimbursed for that. We've got to do the studies, we've got to do the research, and then, attach some economic evaluation to that, and then go to the payers. So the stakeholders in that are us, the clinicians, the patients, the payers. They need to be at the table with us. We need to hear from them. What is it that they need to see, for them to say there is value in us paying for this. Back when we did the diabetes study, the payers were not a part of the study, but they did know that we were doing it. So halfway through it, they said, let's see what y'all already have. We gave them the data. We did not run it ourselves. We gave them the data. They analyzed it themselves. And then they came back to us and said, look, y'all have already saved us this much money just in these patients here. Yes, we will work with you and we will pay for this. So that's how we got that, that reimbursement, done. So this is how we do this. This is how we need to, to work together to get those things paid for. Another big barrier too is the co-pays and the deductibles. Even when it's paid for, if you've got people that are insured, but they still have these large co-pays and these large deductibles, that's still an issue. So, we've just all got to work together and do this work and prove it out and figure out what is value to these different stakeholders.
Tressa, I know you have a few thoughts on the reimbursement side. Can you talk about the pushback from payers and how this issue of focusing on quality of outcomes versus what mode is a patient is interacting with a healthcare system to get the care they need, video, in-person, voice. Can you talk about it and what the uphill push is here to try to get reimbursement so that really you're delivering the best care to the patient, however it works best?
Yeah, thank you. I think it's very interesting that while we're under this state of emergency, there's been a lifting of some of these somewhat silly rules that are barriers to patients receiving actually really good care via these new means of technology. There are three specific areas, Liz, I want to touch on as it relates to this topic. And Terrence hit on one of them, and that's payment parity. Does it really matter if the discussion took 2 minutes or 20 minutes if the outcome was the same and appropriate and worked for the patient? So that's argument one. And when we talk about disadvantaged populations, if there's a clinically appropriate intervention that can occur on that phone they borrowed from someone because they don't have internet or because they don't have transportation, again, these silly rules have just created a barrier for care. So that parity is one aspect. And I've worked with the Maryland Hospital Association and the legislation here in Maryland. They have this top of agenda, but it's very interesting because we're having to solve for it on a state-by-state basis. The other thing right now that we're seeing that we're protected from under this state of emergency a little bit is each of the insurance companies have different rules. And, the care providers will tell you, boy, I did not get into this business to understand that, United's going to do something different than Blue Cross Blue Shield, than Medicare, than Medicaid. And they just want to be able to deliver care parity for the care condition. And putting all of those barriers in front of care providers on delivering a lot of care that they're worried they won't be reimbursed for, they're now having to make a decision between, do I do the right thing by my patient or do I put my own business at risk? So again, we made it really complex with allowing all the insurers to come up with their own rules around this. And then finally, I talked a little bit about workforce shortage. It doesn't help if we have all of these rules about credentialing, where you've got to have a specific care provider credentialed in your state to do the same thing that a patient a mile across the state line can't provide care for. So these are three areas where we're super excited that we have been given some forgiveness during the state of emergency, because I think that is a recognition that there's more work that needs to be done to get rid of these as barriers. But again, Liz, this is not about the technology. It's about payment parity for outcome, not for the resource intensity. It's about simplifying the capabilities if the outcome demonstrates that they're going to be effective for these patients. And it's about simplifying credentialing and acknowledging that someone who can provide behavioral health services in 2 or 3 or 5 states, why not 50? What kind of a rule is that?
Isaiah, pick up on any of those points, but could I also ask you just to put in real world terms what it means to some of your patients, considering the stresses in their lives and what they have to juggle to get into a doctor's appointment, the ability to have access to telehealth, and others, why we need to reimburse this option. And as I said, if you want to also address any of the other points, please feel free.
I'm just happy to be listening to such profound statements by the others. I'm trying to sit here and figure out ways that I can add value. And I think it is at the patient level, but it also is at the staff level. So if I talked about it earlier, but let me make this very clear. Healthcare of tomorrow includes telehealth. I'll say that one more time. Healthcare of tomorrow includes telehealth, not without. In my opening statements, I talked about Delaware Valley Community Health being in urban environments. Prior to the pandemic, we had zero telehealth. We did not go into it because it wasn't reimbursed. We thought about it. We thought it could be an option. We had zero. The day after the pandemic was declared in Pennsylvania, we went to 100%, and our patients love it. But the very practical nature of telehealth outside of the tech is the fact that it keeps people employed and it keeps the patients employed. For a single mother or a single father that has multiple children, and they can have a primary care visit, a dental visit, a behavioral health visit, all in the same day. How can that single parent adequately provide that care to their children? Telehealth is the way to do it, because you can switch modalities. And I talk about our integrated care model in Delaware Valley Community Health. By having our next-gen EHR integrated into our virtual visits, we're able to just add the providers to those visits. That's impactful. So when an actual patient, they have to take off from work, they don't have to take off an entire day just to have 3 different visits. They can take off within an hour or 2 hours, and then they're back on the clock, providing for their families, because those hours off are hours not making money for their families in which they need to do it. But at the staff level, we've been able to increase some of our institutional knowledge by having people go home and be able to work from home and do the telehealth triaging options. And so one of the things that we've done from a technology perspective, just to take something else, is that we put that infrastructure on us as an organization. Delaware Valley Community Health increased our broadband access, because that's the other thing that I wanted to throw in that might be a little bit different, is that increasing broadband access to urban areas, increasing device access, because once you do that, you provide health equity to all those that need it. So we look forward to continuing the conversation at the federal, the state, and the local levels. But again, healthcare of tomorrow includes telehealth and all the modalities tied into.
David, when we were talking earlier, you talked about that providing telehealth services and remote access actually has implications that could extend into senior living and senior care and improving it. Can you talk about that a little bit?
Yeah, so I think people in the pandemic, there were a lot of unnecessary deaths in nursing homes, right? And part of it, when we were working with nursing homes, they were pretty, quickly to identify that they did not want physicians coming into the nursing home, because physicians were seeing the most sick patients and were a vector into the nursing home. So they went to telehealth as a way to get the clinical care they needed to know, is this patient okay? Do I need to change their medications? Or do I need to transfer them to a hospital? Knowing that if you transfer them to a hospital, you're taking a risk about COVID early in the pandemic. I think some of that, what we've talked about today, is the use of telehealth is a way to improve the productivity of providers, to get the right provider into the right situation at the right time. When we were talking about if there's only one person in the health system that can do the social determinants for an ER at 2 a.m., sharing them around multiple places. So I think we've seen a lot of productivity changes there. So I hope those continue, because those changes are ones that, to address this point, I used to live in Kansas City. If you're on the Kansas City, Kansas side or Missouri side, why do I have to drive 2 miles different because of that? It absolutely makes no sense. And so at a minimum, we've talked to state governments and said, at least let bordering states treat, right? So these kind of protectionist policies about, okay, I don't want everyone in the US, okay, fine. But at least pick your bordering states. And we saw a good uptick on that in places like New York, for example, which is about as protectionist as it comes as far as state licensure. But when they didn't have the resources, they were happy for people from New Jersey or Connecticut to help treat people virtually because their systems were overwhelmed. I think we need to take those lessons forward and not forget about them, to Trust's point, and actually enact changes that make that easier for us to be ready for the next pandemic, which there hopefully won't be one, but if there was, we won't find ourselves doing the same thing again.
Thank you. We just have a few minutes left. I want to hit a few more questions, a couple more quick questions. Tirsani, when we talked about the importance of telemedicine and reaching people who cannot get to cities easily, but you made a really important point about the fact that people can access quality care in their small towns and how important it is in keeping local clinics alive and in those communities. Can you talk about how critical that is in sort of the lifeblood of a town, and improving inequities in care by keeping care local, and how that confidence is built by these connections that you're able to form through telemedicine?
So I'll talk about that specifically with emergency medicine. So I think that's probably our best story that demonstrates that. So back when I talked about the teleemergency program, which really birthed our telemedicine here in Mississippi. So back then, our emergency medicine physicians here at the medical center were already advising the emergency providers out in the state at our critical access hospitals. They were getting calls already, asking them, hey, I've got this patient in the hospital. We're thinking about transferring them, or we've got this going on. Do we really need to transfer them? I've done this, what do I need to do? And they were already advising them, right? Because we were the only level 1 trauma center, only academic medical center. Many times they had trained these physicians. A lot of times these may have been general practitioners, moonlighting in the ERs, sometimes nurse practitioners moonlighting in the ERs. already, right? So they were already doing this. And one night, one of the physicians said, if I could only see the patient, I would know whether I was doing the right thing, by telling them to bring the patient here. Because oftentimes the patient would get here to the medical center and we would do a few things and send the patient home. So now somebody has got to come 2 or 3 hours to Jackson, pick this patient up and take them back home. So that patient really could have stayed, in that hospital, or even if that patient did need to be admitted here at the medical center, they were admitted for a day, so they could have been there in that hospital. So what we did was we created a program where we trained nurse practitioners who could be employed by that critical access hospital to work in that emergency department. And our physicians here at UMMC serve as their collaborators. So they work there in that critical access hospital full time. We are the collaborators. They continue to see the patients there as they normally would. But if they need that additional backup, they get that backup from our physicians via telemedicine. So our providers can see these patients, they can talk to the patients, they can assist with assessments. Now, those nurse practitioners are trained and they know how to do the procedures, but just think if you haven't intubated somebody in 6 months, you may need a little bit of help, somebody to walk you through. But in the event that nurse practitioner has to transfer that patient, that provider who is assisting them with that assessment and with the treatment of that patient is the provider who is going to receive that patient. So they know what that patient looked like when they were in that critical access hospital. So when they receive that patient, they don't have to repeat tests, because they know this is what the patient looked like, when they left that hospital. They are still stable, they're okay, they're fine. But also, if they stabilize that patient, the patient may be able to stay there. So that's increased revenue for that hospital, for that community. And it makes the care received in that local community more on par with what is received in Jackson. So what happened over time is that community, the confidence in that hospital increased. That community starts saying, well, okay, I don't have to bypass this hospital anymore, because if they need to, they're going to call Jackson anyway. I'm going to see the same provider that I would see if I were going to Jackson anyway. So I don't have to delay care, because what was happening is by the time they made it to Jackson, they were in worse condition if they would have just stopped in Lexington. As a matter of fact, that hospital stayed open because they were able to see patients because of teleemergency. And we have several of those stories, around the state because of teleemergency and the ability for that emergency department to see more patients and keep more patients in-house. Of course, their census increased. That's more revenue for that hospital, and they were able to stay open.
Thank you. So in our final comments, I'm going to go to Isaiah, Tressa, and David. Tressa, can you pick up on one point, which is sort of filtered through a lot of your comments, which is, can you talk a little bit about the importance of trust with your patient population and how that impacts their willingness to engage with you through any channel, and that technology is dependent on that? Can you talk about that just a little bit?
Yeah, happy to. And I'm going to lead with saying we've got to do better in this area. All underserved communities are put in situations of embarrassment, of insensitivity. The ability for our health records to ingest social determinant information will only be maximized if we learn how to effectively use it. We do need to meet people where they are. And in fact, many healthcare organizations are looked at very analogous to government organizations, and they're just seen as these large institutions of mistrust. And so we're learning how to connect better with our communities at Lifebridge. We've got some very, very diverse communities. They cross the spectrum, and we have to have different mechanisms to really make sure that we're creating a safe space for that trust to be reestablished. A couple of examples: and I'm sure others have done this. We now have in our arsenal very, very good relationships with our faith-based communities, meaning that the institutions of faith and religion in a variety of our settings, they are a trusted partner to the people in our community. And sometimes we need to enlist them to help us reestablish a trust relationship with someone who really needs care, but for whatever reason, maybe it's a memory of a lost loved one, maybe it's just other factors, it's just not happening. So we've got to get very creative. A recent opportunity for us in the inner city of Baltimore was a partnership with LiveChair. It's a partnership through Care First. LiveChair is a startup that takes advantage of the fact that African-American men go to the barbershop quite frequently. And during the pandemic, we had an opportunity for really healthy guys to be established or connected with a primary care doctor that might not otherwise occur because they didn't need it. And then as some of the barriers about immunization or COVID came about, these folks who otherwise didn't have any connectivity to a healthcare system now had one through a relationship with their barbers.
That's great. Isaiah, we did get an audience question that I just wanted to send to you, which is the access to devices and broadband. And part of showing sensitivity to patients is awareness of what their resources are. Can you just very quickly, in the minute or two we have, talk about what you did on the broadband issue and how you dealt with the device issue if a grandmother doesn't have a smartphone, et cetera?
Yeah, very quickly. One of the things we did is we wanted to make a light imprint on telehealth and wanted to make it not this bloated application that took you a bunch of different megabytes, gigabytes, a bunch of different resources just to connect to the provider. So what we did is we increased our WAN infrastructure to be able to handle the multitude of requests that we would get. But similarly, we made sure that the devices that you could have or we could sponsor you to get with a lighter protocol were able to connect. And so in the situations of a grandmother who doesn't have a cell phone or something like that, the process will be very simple. You would identify that at the point of care, and then what we would do was put you into a program and or supply you with a device from the government or the like. And then after that, we will make sure you had a caregiver. If it was a grandson or a grandniece or an aunt or uncle to that grandmother, we made them a part of the care because, again, as an FQHC, typically we know the entire family. So we say we see from 0 to 99, and that's everyone included. So being able to know who your caregiver is and or not have a dedicated resource from Delaware Valley Community Health to be able to help you navigate through how to get connected, how to use the cell phone or the iPad to get connected, are some of the ways that we handled that device and broadband issue.
Thank you. David, can you give us a final comment? Looking a few years into the future, where can improvements still be made through technology and telemedicine or analytics to improve care? Where do you see it going?
I agree with Isaiah. I think telemedicine's here to stay. With Tierney, that the remote patient monitoring is here, and I think it'll improve substantially as you go forward. You'll see more devices and more maybe artificial intelligence around that, so people can be treated by lower skilled. I love Tressa's point about getting more people to be able to connect so that we can kind of take away a little bit of the clinician shortage by getting people to treat people wherever they are and be very efficient through that treatment. And then I think you'll see on the analytics side, we've done a lot with, we call it the Next Gen Community Health Collaborative, where we're taking data and just giving it back to clients to say, where are you best practices and where are you not? So just to give people a benchmark of where are you on this journey so you know where to go. So I think the future looks bright as you think about all four of those different vectors as we go forward. So I'm excited.
Thank you. Well, Dr. Tierney Davis, David Sides, Tresha Springman, Isaiah Nathaniel, thank you for really engaging substantive conversation and for offering all of us real reason to hope that through the work of dedicated leaders and innovators like all of you, we may finally be able to rectify some of the stubborn inequities in our healthcare delivery system. Thank you all.
Thank you, Liz.
Thank you.
Thank you.